Hi, it's Dr. Centeno, and this is the lecture that I gave at the Orthobiologic Institute, or TOBI conference, on PercACLR. So ACLR, or ACL reconstruction, has really exploded. We've seen a 300% plus increase in the number of women getting ACLR procedures, and a 924% increase in patients less than 15 years of age, which is pretty staggering. So we have an epidemic here, certainly of young women, ACL ruptures or tears, that are getting surgically reconstructed. Now, based on what I see, there are three questions that we should be asking here. Number one is, will reconstructing the ACL prevent arthritis? Because that's a very common question I get from patients. Number two is, will the surgery help the patient get back to sports quicker? That's another very common question I get. And number three is, will the knee ever be the same post-surgery? Because what I hear patients want is they believe that their knee is getting fixed. And obviously that the knee is going to be exactly like it was before they tore the ACL. So let's take the first one. Will ACLR prevent osteoarthritis of the knee? Obviously, that's really why most patients I see sign up. They want to prevent bigger problems down the road, or they want to get back to sports more quickly. So the answer, regrettably, is it won't prevent osteoarthritis. We have a number of different studies, including this one, that shows that at the end of the day, it really didn't make a difference whether or not you got your ACL reconstructed or not. You still ended up with osteoarthritis. Second most common question is, will surgery speed or increase return to play? People want to do this surgery because they want to get back to playing their sport. And again, the answer is not what you would think. Really, we have studies that show that there isn't a difference between getting the surgery and not. In fact, the patients that end up getting no surgery tend to go back more quickly than those that get the surgery. Another question is, will surgery fix my knee like new again? Again, it's the expectation of most patients that get this procedure that their knee is going to be exactly like it was before they tore their ACL. And regrettably, again, that's not true either. We have a number of different studies that show everything from deficits in muscle strength to proprioception and the ability to land normally on that knee. So all of that begs the question, can we repair the ACL or regrow the ACL right where it sits? Another word for that in medicine is in situ. So if we're going to consider how we might repair the ACL and regrow it, so to speak, if it has a tear, then one possible candidate for doing that would be bone marrow concentrate. And why would something like this work? Well, we know that ACLs have a sheath around them that can act as a live scaffold. We also know that bone marrow concentrate has mesenchymal stem that can orchestrate a repair response. And while the ACL has some areas where it doesn't have good blood supply, we know that some of the components of bone marrow concentrate can reestablish blood supply. If we look at the ACL anatomy, we have two bundles, the anterior medial and posterior lateral bundle. So if we're going to inject bone marrow concentrate into the ACL, we want to make sure we get good coverage of that. We want to get both the anterior medial bundle and the posterior lateral bundle, so we've got to come up with some specialized techniques to do that. And I would also have you notice how intimately associated the meniscal roots are with the ACL-PCL complex. So if we look at ACL tear types, there's lots of different ligament classifications and subtypes that you can find online and in books. But from a regen med standpoint, we only really care from a 30,000 foot view about this. Is it a partial tear? Is it a full thickness non-retracted tear? Or is it a full thickness retracted tear? Now, we have further narrowed down the types of tears that respond within these two categories, and even within the third category. But from a 30,000 foot view, we would think that we'd want to focus our attention on these two tear types because they're the most likely to respond. And what I mean by non-retracted is that it hasn't pulled back like a rubber band. For a full thickness retracted, it's torn and it's pulled back like a rubber band. For a full thickness non-retracted, it's torn, but it hasn't pulled back. So again, if we have our ligament here and we have a partial tear, there's just a little bit that's torn. We could have a full thickness tear where it has not retracted yet. And then we can have a full thickness tear where it has pulled back like a rubber band and we see two pieces with a big gap. So again, I think we'd want to focus ourselves mostly on these two initially. So choices for injecting the ACL. You can do this blind. You can do this under musculoskeletal ultrasound. You can do this under fluoroscopy or a real-time x-ray. Or you could do this under arthroscopy even. You could stick a needle in there while you're doing arthroscopy of the knee. Blind injections, the biggest problem there is we've tested this under ultrasound and fluoroscopy, and it's very unlikely to get into the ACL blind. So if someone tells you they're accurately injecting the ACL blind, they've never really looked to see that's the case, because I would estimate that 2/3 of the time they're nowhere in or near the ACL. Then you've got the idea that you can do this under ultrasound. And one of the problems we've seen under ultrasound is that from the front, you're only ever going to see, this is the tibia here, you're only ever going to see a small portion of the ACL that you can visualize. And actually only this area can be well visualized down here. And then you've got this, what's called hyper or hypoechoic area. So this is hyper, meaning you can see it. This is hypo, meaning it's dark. And then the ACL actually really continues all the way up in here, and you're going to struggle to see much happening here, but let's say you can, but you're not going to be able to see what happens to your injectate once it gets up into this area, which is a problem because you want to make sure that you get injectate all the way up. So this is an x-ray image. Here my needle's coming in about the place it would be if I was doing this under ultrasound. And you can see that the ACL should go all the way up into this area, but it's not. The dark stuff here is what I'm injecting, and the dark stuff is dumping out the back and accumulating in the back of the knee. So it's very common to see a tear in the back of the ACL. And so you inject at the bottom where you can see it under ultrasound, and regrettably it dumps out the back, and that creates a problem because you never really get any of this stuff injected into the upper portion of the ACL at the origin. Fluoroscopy, the good news is you can see the ligament all the way through. The bad news is fluoroscopy costs a lot more money, and it's interesting when you start talking to doctors about fluoroscopy and ultrasound, what it really comes down to is money. They just don't want to spend the money on getting a fluoroscopy unit. They don't want to put together a room that could house that unit, which needs to be specially shielded. So it really comes down to money many times if they're doing this under ultrasound. Arthroscopy. I think we did the world's first arthroscopic ACL injection with stem cells way back in 2012. And this is from a mini arthroscopy unit. You can see the needle coming in here. That's the ACL that we're looking at there. The good news is you can see the whole ligament and you can get into all the different parts of it. The bad news is this is even more expensive per unit cost than the other two. But a bigger issue is not so much expense, is that it's more invasive than the other three methods, meaning that you're taking more risk with the patient by initiating an arthroscopy So you better have a good reason to take that risk, meaning if it can be done in a less risky injection procedure under x-ray, why would you take the additional risk of arthroscopy? Certainly not because you just happen to have the equipment lying around. So our history of injecting ACLs with stem cells goes back quite a ways. In 2010, we tried to inject under fluoroscopy the ACL, and we got pretty inconsistent results. By 2011, we had better results at the tibial insertion, so we were starting to dial in a little bit. By 2012, we tried to inject under needle arthroscopy. Looked promising. We did some ultrasound injections, looked kind of promising. But by 2014, we'd really started to dial in the fluoroscopy or x-ray guided approach and made some major advances in 2015, especially focusing on double bundle techniques and understanding of the ACL meniscal connections. So long story short is we've been doing this for a while, and it's taken quite a few years to dial this procedure in. You would think it would be just as easy as sticking a needle in there, but it's not. Our ACL research history in 2014, we published a small pilot. We also that same year began a randomized controlled trial. In 2017, we submitted a bigger case series with computer-assisted MRI analysis. One of the things you should also know is that we tend to use what we call HD-BMC. So when we're using bone marrow concentrate, we're using the high-dose form of that in a lot of these trials you're going to see in some of this data. So this is a multi-cortical site, low volume per site BMA. It is not your standard just stick the needle in and pull 30 or 60 cc's, or stick the needle in deeper and pull as you come out. This is a different technique that we've seen gets a lot more cells than either one of those approaches. We also process it differently, so we're getting to very small volumes and higher concentrations. So the total nucleated cell count here is greater than 200 million per ml generally. And again, this is not a 60 ml BMA that's taken from a single site, put into a harvest machine that gives you 10 cc's, where it'd be very unlikely that you're going to get 200 million cells per cc to re-inject. So this is our ACL injection experience by the numbers. Total stem cell cases being tracked in our registry right now is almost 8,000. Total knee cases is almost 5,000. The total number of knee cases where the ACL is injected for any reason, and that includes a lot of cases with just ACL laxity but no known tear, is 758. And that breaks down further to 157 cases where there was a known tear, but the ACL was injected with something else, let's say a meniscus, and 37, which is more rare, where there's an ACL known tear and absolutely nothing else was injected. So our pilot study a number of years ago, 10 patients, partial and complete non-retracted ACL tears. We saw objective changes in MRI. Before and after, we used computerized histograms to be able to quantify those changes, and 7 out of 10 patients reported clinical improvement. How long did it take for these changes to happen? These are some serial MRIs, and these tend to be in older patients, where we're seeing a time course here of really 11 months, as you can see, for this ACL tear to get complete. So obviously this is blown out tight morphology. You can see some fibers coming in that are being oriented here. You can see a little tighter morphology here. And then by the time you get to 11 months, you see a very tight, more normal looking ACL morphology. Here, again, this is along the 9-month time frame. So this is again a patient in their 30s, where you see a very obvious blunt edge tear here. By 5 months, we're seeing some good healing of that blunt edge tear. And then by 9 months, you're seeing really a normal ACL type morphology. And it's always good to be young, right? This is 3 months. So we see here a patient who in just 3 months was able to go from a blown out type ACL morphology. She's in her 20s from Singapore. She flew to Colorado to get the procedure. And only 3 months later, this is read out as normal ACL. So you can see that as well in younger patients. As far as our larger case series is concerned, this is N equals 31, paper that's in submission. And we're still seeing statistically significant changes in MRI histograms consistent with ligament healing. These are ACL-only injections. This is the modified SANE score for percentage improvement over time. This is the lower extremity functional score, which is similar to IKDC as a functional score for increase in function. As far as re-tear rates are concerned, one of the things that's very important to us, not only in ACL, but also in other areas like knee osteoarthritis, is trying to make sure that we can make Regen Med reliable, because we're beyond, listen, we've been doing this 12 years. I think Hernigau is the only other person out there that's been doing this in orthopedics longer than we have. And, we're at that place not of saying, does this stuff work or where does it work, but how do we get it to be more reliable in how it works? So one thing obviously is adding additional demographic info beyond, just age and sex, i.e. candidacy grading based on MRI, but then going beyond MRI. So this is some data from a research study that we're doing we're measuring 25 growth factors and cytokines using microarray multiplex ELISA and correlating those levels to knee osteoarthritis with a bone marrow concentrate injection in the outcome. Again, this is not ACL, but knee osteoarthritis. And what you see here is this is some of the data that makes up the artificial intelligence model that we're using. So we're going to rerun this model this summer. Last time we ran it a number of months ago, it was 84% accurate just based on the chemicals in someone's knee and predicting how they would respond. And you can see here, these are the cytokines and growth factors that we're measuring. And if they've got a bigger bar here, these growth factors tend to have more of an influence on outcome. And then obviously there is trying to look at the ACL procedure, so focusing in there. And looking at a bunch of these just recently, and I looked at about 50 before and after MRIs, really spent a large number of hours doing that, and I'm still doing it while I'm here in Las Vegas. It really seems to come down to offset and morphology are the two things that predict whether someone's going to respond. Now the offset is the degree of posterior translation of the femur on the tibia. So the ACL is oriented like this, so it limits that posterior translation of the femur. And so the farther back the femur is relative to the tibia, and you can see a measurement here of 9 millimeters, the more damaged the ACL is. So the offset itself, I think, is important in looking at whether or not someone is a responder. And initially we thought the offset was the end-all be-all. And regrettably, it really didn't turn out that way. We believe the offset is important, but morphology of the tear is likely as important. And we are in the process of creating a candidacy tool that will be used by our medical network providers based on offset and morphology that will allow them to get a candidacy based on both offset and morphology, based on what we know right now, and that the tool will evolve as time goes on to get more and more accurate in predicting who is going to be a great candidate for this and who really should not undergo the procedure. So one pointer I can tell you from looking at all these MRIs as I'm putting together the algorithm based on that data is that if you see no tissue that connects from the origin to insertion, obviously you can see some tissue here, you can see some tissue there, but nothing that's going from point A to point B. Even if you eventually see some proto tissue after a BMC injection, and we've seen some of that, where you see some new tissue laying down in there, it's almost 100% chance of failure on a post-injection MRI or re-tear of that proto-tissue. So long story short is it's an issue and a problem. These are the re-tear rates here that we have been able to look at. If I remove the no tissue cases versus the bad candidates removed. So what not to do for a professional athlete. This is an ultrasound guided BMC injection. This was done at a famous orthopedic sports medicine clinic where a professional athlete was treated, and I don't think that what was done here was effective for this guy, and I'll show you why. So this is his original post-injury MRI, and while we see some ACL tearing here at the origin and insertion, the good news is this was read out as a partial ACL tear. Is it truly partial? Personally, I would have put this in the complete non-retracted world rather than partial, but the radiologist put it in the partial world. So he ended up getting a BMC injection under ultrasound guidance, and that was here. And I can tell you what happened based on his result is that, as we saw before, the BMC went up about halfway and dumped out. And in particular, the BMC never got to this upper part. So what do we see 6 weeks after the ultrasound-guided BMC injection at the tibial spine? We see a blunt retracted edge right here. So basically, the part that was really never treated with bone marrow concentrate in all likelihood retracts back. So this guy is not in a good spot. His offset went from a very mild, nice 4 to 10 plus, which means that he's having ACL failure occur. And this also shows you what happened here. So this is when I saw him. You can see here contrast in the good part of the ACL that comes up this far, but really doesn't go into the blunt retracted area at all, which is outlined right here. And you can see right here on MRI. So it doesn't make it into that area. I was able to get the needle above that into the blunt area and get a little bit to flow down, and he now seems to be on the mend. So this is ACL randomized controlled trial data. So these are knee ACL tears. Basically, this is a 3-month crossover. These are surgical candidates of completes, non-retracted, and measuring lots of different metrics that you'll see here. And this is about halfway recruited. The recruitment goal was 50. So you can see here, this is the mean SANE score, which is the single assessment numeric evaluation, which is percentage improvement of the exercise group versus the treatment group, and statistical significance there. This is the MPS scores, numeric pain scores between the two, and statistical significance. And then this is the LEFS score, which is a lower extremity functional metric, and statistical significance between the two. And this is the IKDC score between the two groups. So in summary, we've seen game-changing results with precise ACL injections under fluoroscopy. Musculoskeletal ultrasound can be used, but I would tend to use it when there's more a partial tear or when there's just laxity. But because of what I showed you here, it's not likely to be standard of care for this procedure, certainly in injection-based non-surgical approaches. And we've developed a candidacy tool for network physicians that's still in process, but we should have it done here in a week or so. It'll be used by our network physicians so that it gets better and better over time in predicting who's going to be a great candidate for this and who's not going to be, or who's more likely to have a re-tear, etc. I can tell you that no tissue equals no long-term results, and that our RCT results look promising, and we'll continue to recruit for that study. So thanks so much for watching, and have a great day.